All right, welcome to the first official episode of the Humanosity podcast. I have a very special guest, someone that is probably the perfect person to start this podcast off, that I'm very happy to have. His name is Dr. Paris Williams. He's a clinical psychologist, currently licensed in California, Utah, and Colorado, where he resides. He has pioneered research studies along with his academic research, emphasizing somatic, humanistic, existential, and transpersonal perspectives. His doctoral research on links between developmental trauma, psychosis, and other extreme states of mind was translated into the widely acclaimed book, Rethinking Madness, towards a paradigm shift in our understanding and treatment of psychosis, which I highly recommend checking out. In 2013, he moved to New Zealand, where he worked as a clinical psychologist for 10 years before returning to the US. Throughout his professional career, he has worked at a residential facility, a major medical hospital, a community mental health clinic, a treatment center for substance dependence, the New Zealand ACC system, and private practice settings. He has also facilitated dozens of workshops and trainings and has extensive experience in providing supervision to health professionals. He is a true expert in the field, especially understanding the development and treatment of psychosis, which I will be talking to him about today. Dr. Williams, welcome.
Yeah, thanks, Zach. Really nice to be here.
So starting off, I just kind of want to give you a background as to how I got introduced to your work. So I've been working at a behavioral health unit on a hospital for 4 years now. And at the time, I really didn't have any interest or desire to work with people who were diagnosed with schizophrenia or going through episodes of psychosis. I never really thought much about it in grad school. And I sort of just had the basic idea that it was some sort of brain imbalance or abnormality, and that the most effective treatment was medication. So I didn't think too much about it. And the year I started working at the hospital, I really started getting into Carl Jung. I started reading him for the first time, and he was the first person I read that talked about the psyche having a telos, an aim, a purpose, a goal of adaptation and stabilization and development. Um, Sort of like the body having its own wisdom and knows how to develop and stabilize. And that's sort of what you talk about with your concept of having an organismic wisdom or intelligence sort of guiding um, our beings. Um, and so at that same year, that's when I read your book and really shifted my perspective on things. So that's what I want to talk to you about today. And just starting off, could you just define what psychosis is?
Yeah, great question, and not a super easy question to answer, really. There's different definitions people use, and generally, how I define it is it's a combination of someone having anomalous experiences or beliefs. And what I mean by anomalous is they're outside of what the particular community of that person would be deemed as acceptable or truthful or valid. So those are anomalous experiences or beliefs. And then, in addition, they need to be distressing in the sense that they're undermining that person's needs in some way, and or have a kind of chaotic flavor to them in which they might be shifting around. So obviously, a person can have anomalous beliefs and not be in a psychotic process. Like, for example, if one religious community would seem to be psychotic to another religious community if you just simply used anonymous beliefs as the criteria, which often is used in our field. But that's why I add the additional criteria of having to be actually distressing, undermining needs in some way. And typically there's going to be a kind of chaotic flow to it. And, it's not necessarily, they're not necessarily going to have a sort of stable um, flavor to the particular experiences or beliefs. So that's how I find is the most helpful definition for that term personally.
Yeah, that's a very good definition. Can I ask, or can you talk about what led to your interest in extreme states? episodes of psychosis and where that led you career wise and academically.
Yeah, kind of interesting. Well, first of all, my mother would be she, according to the kind of standards or DSM criteria, she would be deemed as having a psychotic disorder. However, she's had this very stable belief system throughout my whole life and doesn't seem to really undermine her needs. Like she's actually functions really well. She's never been hospitalized on meds or anything. And so that was kind of a beginning of like, okay, something a little off here. Like she's actually doing pretty good, but she has some unusual beliefs. And then, um, and then I ended up having a kind of breakdown in my late 20s where I definitely went into a kind of process where my whole construct of the world and self and other like broke down. So this was quite different than what I sort of experienced with my mother. I definitely went into a kind of chaotic process where my all my belief systems, my constructs about the world, became quite chaotic. And fortunately, I had a really strong mindfulness kind of meditation practice when that all happened. So I had the wherewithal to kind of just turn into practicing that mindfulness practice, and I had the wherewithal to just spend a lot of time in an embodied way, like running and swimming and just really, connecting to nature. So I was just really resourcing myself and not spending too much time in the kind of chaos that was going on in my mind. So I was fortunate that I had the wherewithal to do that. And I also recognized that I had quite a traumatic childhood. And here I am almost 30 and this is happening. And I recognize, oh, this is so much material from my own childhood that was deeply repressed. It's all just kind of like the dam burst, basically. It's all coming out. It's kind of overwhelming me. But if I go to a mental health professional, there's a good chance I'll get diagnosed with a psychotic disorder because I was having some pretty bizarre beliefs and perceptions and things. And I'll probably get put on some heavy drugs and given a label. And it would actually kind of I was already living in a lot of fear, and now somebody telling me that I had a broken brain would just probably be unbearable for me to hear that from a quote unquote professional. So I managed to avoid the system. I sort of knew better, and I avoided the system, and I kind of I was able to put on a good front to my friends and others. So they kind of knew I was acting a little strange, but was managed to not really alarm anybody. So I had all that going for me, all those resources that are granted a little bit unusual. And I came out the other side. It took me really a couple of years to kind of get through it. About 6 months was the worst of it, and then maybe 2 years to really feel like I was really through, the tunnel. And I felt so much better than before I went in. Like I realized, wow, I actually had some really profound healing here that happened, and I could feel all that trauma from my childhood. It actually so much of it had resolved. Like it really felt integrated and worked through, and it all happened pretty spontaneously. Like I didn't see a therapist. I did have a really strong mindfulness practice that definitely helped. And I was actually a hang gliding professional at the time. But anyway, that was a catalyst to make me think, gosh, this must be happening to so many other people. This kind of experience. They go into the mental health field. They're given a diagnosis, put on the drugs, et cetera, told they have a brain disease. And then it actually becomes a kind of self-fulfilling prophecy. Like they actually end up becoming lifelong mental health patients, which I think I probably would have become. And I just thought how tragic that is, that happens to so many people. And so then that's when I made the shift into the field of psychology, and ultimately my interest in extreme states and trauma and psychosis and kind of the relationship. And between those, as well as a kind of had a strong kind of spiritual or transpersonal element to the way I was looking at these states as well, because I realized as I was going through them, my whole sense of self was kind of getting deconstructed and dissolving. And I was actually having some really kind of profound unitive type experiences, like really experiencing the deep interconnectedness and interdependence of the universe, of the world, of what I call myself. So that was all happening kind of spontaneously. And then as I started to study other people, I recognized the same links, the links to trauma, especially childhood and early childhood trauma, the links often to profound spiritual type experiences, even though there's often a lot of confusion, between those different
Mhm.
realms. So yeah, it's kind of a long answer, but
I didn't know or didn't realize how personal and your personal experience with anomalous experiences was from a young age. So that makes a lot of sense as to where it led you, and it's interesting to think about the different paths and, like you said, what could have happened if you did decide to seek help. Um, and I think it's important for people who are going through similar experiences to hear hopefulness from a story like yours, because that's often not the case.
Yeah, and I certainly don't want to imply not to seek help. I think I was quite fortunate and I had so many good resources, and I was a bit older when it kind of happened to me. But the challenge is to find the right kind of help, to find people who will be able to support you and kind of finding your own narrative, your own understanding of these experiences beyond the, bioreductive medical model that you have a broken brain. And luckily, there are actually a lot of clinics, therapists, etc., peer support networks. So, like on my own website, rethinkingmadness.com, there's a whole resource page that lists lots of kind of therapist directories and things like that, recovery centers that do come from a much more holistic perspective.
So that leads me into the first thing I wanted to talk to you about, which in your book you lay out at the beginning 4 myths when it comes to understanding, I guess what we could just say schizophrenia. And the first myth you lay out is that schizophrenia is a brain disease. Could you talk about what the mainstream concept or understanding of schizophrenia is?
Yeah. So the term itself, actually, a number of countries, including Japan, amongst many others, have actually eliminated that term altogether now because there's so much false assumptions laden in that term. Like, for example, one of the assumptions that people have, one of the myths, is that you have this is a degenerative brain disease that you'll never recover from, and it will actually generally deteriorate. Your condition will generally deteriorate over the course of your life, and that's been so debunked. But there's been so much research that shows many people actually do fully recover from they satisfy all the criteria for that label, schizophrenia, and then they get into the health system and usually put on meds, etc. And then many of these people actually make full recoveries. And In fact, in the most optimal circumstances, we found that the magic number seems to be about 85%. So, like, for example, in the open dialogue approach in Finland, which is basically a kind of family therapy type model, systems theory model, they have consistently found about 85% full recovery rates. So they catch people with first episode psychosis, and then they actually intervene with the whole family. They start without any meds at all. They found that, and there's been lots of other research as well, that shows that medication is a double-edged sword. It tends to make people feel better in the short term, but it actually can reduce the likelihood of recovery in the long term. So anyway, this particular model started with no meds, or maybe use a little bit to kind of ease, the suffering of the person, or try to get them off as soon as possible. And they found that 85% would fully recover without, any meds at all. Or if they were put on them, they were put on short term and then were able to come completely off. And then 15% couldn't, they couldn't quite get through it. And then other types of research, like the World Health Organization, did a 25-year longitudinal study, 13 countries, and they found that the countries who, ironically, had the least access to Western psychiatric care, and also there were other factors too, but that was a major factor. We're having kind of 75, 70-ish, up to 80% recovery rates spontaneously, full recovery, in the sense that they were no longer having these distressing anomalous experiences. They were functioning fully. So because they basically this was a 25-year longitudinal study where they went back and looked at the same people who were diagnosed over 25 years. So we have this myth that first of all, nobody recovers, and which is completely false. Or even if you're more optimistic, the myth is maybe a few people recover, but the reality is actually the majority of people would recover given the right kind of, like, fully recover without being able to get off all their meds, with the right conditions and the right kind of support. So that's a huge myth that most people still have. And if it truly were, if it truly were a degenerative brain disease, like something like, let's say, Alzheimer's or Parkinson's or Huntington's or something which are very well established brain diseases of the brain, I have yet to see, I mean, correct me if I'm wrong, but I have yet to see any cases of full recovery from any of those conditions. So that, they definitely satisfy the criteria of a degenerative brain disease, whereas what we call schizophrenia just simply doesn't, like, with such a high degree of recovery like that.
I really love that you are hitting on points I had already written down to ask you about.
Okay.
Um, yeah, so that's great. Um, and I was going to ask you about the open dialogue approach and the IPSS study from the World Health Organization, which you already mentioned. I do have two follow up questions. So, if so much of the research has debunked this myth that schizophrenia is a degenerative brain disease, why do you think it is still widely assumed by clinicians in the field that that is the case, or the general
Yeah.
public?
Well, there's a few reasons. One, there's what's called the clinician's illusion. So if you work in a psychiatric hospital, say, and people come in with an acute psychosis, and then they get released once they're considered treated, or essentially what we do is symptom management. So you could look at the drug use, and I don't want to totally denigrate the use of drugs, by the way, because what they basically are is tranquilizers. So they reduce the intensity or the salience of experience, but they kind of reduce it globally. So yes, your terror, your fear, your paranoia, all these things are likely to get assuaged, reduced by those medications for most people. But so is your joy and your love and your passion and your motivation and all these other things, which, it's hard to live a good life without all of that's getting kind of turned down, right? But okay, so they leave the hospital, when they're considered quote unquote treated. And then you're only going to see the ones that come back if you're a clinician, right? So many of those people actually don't come back. So a lot of them actually, even with the, like I said, there's been plenty of research that the medications actually help in the short term for many people, but in the long term, they actually they make chronicity of the condition more likely. So, in given our particular mainstream mental health system, just already putting them on the drugs, telling them they have a brain disease, which acts as a kind of nocebo effect, opposite of a placebo effect, already we're hurting the conditions for recovery significantly right there. But still, even still, many people still spontaneously recover, and they don't come back to the hospital. So as a clinician, you don't see them again. So you don't see the people who recover. So that's one reason. So there is a genuine kind of illusion that happens. And then the other reason is this is such a profitable industry. So there's basically a kind of psychiatric pharmaceutical complex, the two working together, that where the field of psychiatry rules the roost when it comes to mental health. But actually, if you look at the study of psychiatry, like if you become a psychiatrist, you're just basically a medical doctor with some extra training. And often the training is really coming from this reductive medical model approach to labeling subjective experiences with, different, what we call DSM labels, mental health conditions, et cetera. But very few of them actually learn to do any kind of psychosocial interventions themselves. They're pretty much just drug prescribers for the most part. And so the combination of the kind of psychiatric field and the pharmaceutical field, they rule the roost of the whole mental health field, which is a multi-billion dollar, multi hundreds of billions of dollar profitable field. And there's so much incentive to maintain that status quo. And schizophrenia is almost like that's sort of the golden egg in a way. It's like if you attack the whole construct of schizophrenia in a way, like the whole edifice of that medical model system will kind of crumble, because it's sort of, yeah. So it's quite. I mean, I've faced this directly myself, just in my own work. I'm definitely upset some people with my work and my approach to this, and higher those in the kind of higher echelons of the field. So I'd say those are probably the major reasons why we're sort of still stuck in that myth. And of course, there's other factors for sure. I mean, another factor is the reality of, why do people go into psychosis in the first place? All right, and that's typically lots of research about it. Typically associated with developmental trauma, childhood trauma, and the world is kind of steadily entering into increasing social inequalities and lots of factors that ultimately increased other factors like domestic violence, child abuse, sexual abuse, all this kind of stuff. So there's generally been a kind of increase in most of those things, which then can create an increase in people going into psychosis. And then once they're on the psychiatric sort of treadmill, they get the label and the meds and everything, right? So that reinforces the whole story. And once you are on the meds, like I say, it does make the chronicity much more likely, which again reinforces that belief that people don't recover.
Right. And you brought up a really important point with the clinician illusion. Working in a hospital, you see a lot of people come in very acute distress and very extreme states. And in a few days, sometimes they're in a much more stable state of mind and they clear up, they're discharged, and then you may see them again in a couple months. And the initial approach to them is, well, you stopped taking your meds, didn't you? And they're like, yeah, I haven't been on them for a couple weeks or months. And then it's, well, that's what's going on. That's why you're in this state. And one of my pet peeves a lot is you hear patients being told, well, you need to be on these medications because it's like a diabetic taking insulin. Um, and so my other question is on the theory of dopamine supersensitivity, where you start on the antipsychotic and then over time it leads to an increase in dopamine receptors, and when you stop, it prones you to experience psychosis again. Could you talk a little bit about that?
Yeah, so supersensitivity psychosis is sometimes called. All psychoactive drugs basically work like this, where your brain treats it as a toxin. The drug is, by definition, a psychoactive drug passes through the blood brain barrier. Your brain is like, oh, this is basically a toxin. We have to counter the effect of this drug. And so you look at an antipsychotic, what does it do? It blocks dopamine, certain parts, certain regions of the brain. And so the brain tries to counter that by like, oh, we're not getting enough dopamine. So it counters that by creating more dopamine, essentially, more dopamine transmitters, receptors, et cetera. And so then you actually, now you have a brain. So even though the evidence isn't clear at all that there was anything particularly wrong with the brain when the person started, when they had the psychosis, now they do have anomalous brain structure. Like they actually have a brain which has become super sensitized to psychosis because it has excessive dopamine being manufactured. And as soon as you remove the dopamine blocking drugs, now you have this excess of dopamine, which definitely can be a factor. And I mean, look at methamphetamines, right? Methamphetamines essentially really amplifies dopamine effects in the brain, and it's a real leading cause of a psychotic break, right? When someone's taking methamphetamines, for example. So it's
Mhm.
well established when there's excessive dopamine that really primes a person to have, it's the opposite of the tranquilizing effect of the drug. Now everything feels acutely intense. So with excessive dopamine, your whole experience, your emotions, the world, everything is super heightened now. You may or may not go into a psychosis from that, but you're certainly going to be sensitized to. And especially if you've already had, a psychosis in the past. So clearly you've got a kind of vulnerability to that.
Mhm. So it's probably the case quite a bit that people come in because they've used something like methamphetamine, which we see a lot in the hospital, and then they're in these very extreme states, and then they're given a dopamine blocker, which in the long run prones them to experience these states again.
That's right. And again, I want to be really kind of clear. I'm not like denigrating these drugs. Like I think they definitely have a place for people, especially for short-term use. It's you're kind of making a Faustian bargain for long-term use. For short-term use, if someone's in a really extreme, heightened state and they're terrified, they're paranoid and whatever, these drugs can really like help so much to help settle them down, help them sleep. Often just anything to get them to sleep is a huge factor, right? In being able to come out of that extreme state.
Yeah.
Um, And typically, a few weeks or whatever on these kinds of drugs, your brain doesn't really have a chance to adjust to them yet. But once you get to a few months, your brain is definitely starting to adapt by, in this case, becoming more sensitized to dopamine, or I should say, yeah, sensitized to psychosis by the excessive production of dopamine. And so that's the Faustian bargain now. And that actually keeps a person trapped on the drug. That it creates a dependency on the drug, because now if you try to come off, you've got that supersensitivity, psychosis, like, vulnerability. So generally, it's a really important rule of thumb for people. Once they've been on any kind of psychoactive drug continuously for 6 months or longer, or really, I'd say 3 months or longer, really, to be safe, then most likely they need to come off very slowly. And that's another problem in the field, is either it's kind of twofold. Either doctors keep people on the drugs forever, right? And there's so many problems with that, there's so many adverse effects and everything else, or they take them off way too quickly. And so coming off way too quickly off any drug, even antidepressant or anxiolytic or et cetera, coming off too quickly is a real problem. Like now you're really shocking your nervous system is adapted to the drug, and you suddenly pull that drug away, you're going to have like a real anomalous state of neurotransmission within your brain, and that's going to send you into some pretty probably wild directions. So it's really important that people know. And doctors are typically not trained in tapering very effectively at all. They're trained to get people on the drugs, not trained to get them off. And most of the research we have on how people can taper successfully actually comes from the kind of the peer support world. Because again, if you kind of come back to, unfortunately, the dark side of capitalism here, there's a lot of profit to be made putting people on the drugs, and there's not much profit to be made getting them off. So there's so little research on helping people come off. So that is just super important for people to know, that when, coming off slowly so that your brain can readapt to not having the drug at the neurological pace. It takes a while, typically, 6 months or a year, kind of at least, once you've been on for a significant period of time. So that can happen. Oh, I was going to say the other field of research that we have that related to this is in methadone usage. So in methadone clinics, there actually is a kind of incentive to get people, maybe not a profit incentive, but part of the treatment plan is typically to get people transition to methadone from like an opiate, say, dependency, and then from the methadone to slowly taper off. And so there actually is research in that field that demonstrates that, yeah, it takes people usually at least 6 months, if not significantly longer, to be able to taper off in a relatively safe way. And so that seems to translate to other psychiatric and psychoactive substances as well, that kind of time frame.
And I totally agree with you that in acute periods, I think that the antipsychotics are a very important tool in the tool belt for a lot of people. A lot of people experience a lot of relief in that short amount of time. But I don't think there's enough communication with how the patient should approach their long-term treatment.
Right. And yeah, well, then you kind of get into the territory of more psychosocial support, which again, typically psychiatrists aren't really, for the most part, they're not really trained much in that. That's, and so what led them to the psychosis in the first place? If you're coming from the belief that it's some kind of randomly established brain disease, then why would psychosocial support be important, right? We just have to treat the brain disease. And so that is how most psychiatrists generally see it. So it's a totally different paradigm. And there's so much, my book goes into so much detail, and there's a lot more that's come out since that's reinforced that about the psychosocial underpinnings, right? The trauma, particularly trauma, especially childhood trauma, are so highly correlated, and actually they're dose dependent, which means it's not just correlated, but causally linked to psychotic disorders. So like the research is so abundant. And when you come from that perspective, you're like, okay, what was the factors that led this person to have this psychotic breakdown in the first place? And how do we address those factors in their life rather than just throwing them back into the fire, right? They get the treatment in the hospital, and then we just kind of throw them right back into the same conditions that kind of led them there in the first place. Of course, how are they going to recover like that, right? Rather than thinking, okay, what led this person? What are the stressors in their life? How do we support them in sort of resolving and working through those stressors and getting that genuine kind of support they need? Maybe they have significant unresolved trauma from the past still, that's acting as a catalyst. Some good trauma informed therapy can go a really long way for supporting them. And not to mention social work. Like maybe this person's really struggling with homelessness or paying their bills, or they've got substance dependency issues, or they're in a violent relationship or part of town, or so many factors like that that just don't get addressed, which would make a huge difference for recovery.
Which I think is a good transition into another myth that you point out in your book is that people don't recover.
Yeah.
And you mentioned the high correlation and causation factor of early trauma and abuse and neglect. Um, how do you personally, as a clinician, go about working with someone?
Yeah. So, well, generally speaking, when if someone's in an acute state of psychosis, like they've kind of got, now you're the ambulance at the bottom of the cliff instead of the fence at the top. Generally takes it kind of takes a village. Like, you don't want to be a lone sort of therapist really trying to support someone through this, kind of active psychosis. And this is where we have it's just a real problem that we just don't have a lot of really good support other outside of the kind of reductionistic, psychiatric system for that. My work has shifted more to trying to be the fence at the top of the cliff now instead of the ambulance at the bottom. I was doing ambulance at the bottom of the work for quite a while, but as I shifted more into kind of private practice work, it just wasn't really feasible. Like, you really need a kind of team to hold someone who's in that kind of space, and also hold their family too. Like, what, again, we're talking about, why do they have this break? What's going on in their life? What's going on in their family system? All that stuff really needs to be held properly. Um, and I mean, there are some options out, like there are residential facilities such as Soteria Homes, and places similar to that. There's again, on my website, there's some links to different places like that. Um, but generally, peer support or groups like that is going to be they're going to be the most helpful. And again, it's just it's a real miss in our field. It's a real problem that we just don't have enough of that kind of support. So often the only support people have is to go to the hospital. And again, there can be a place for, okay, they get put on the meds, they get some sleep, they settle down, they stabilize, but then recognizing that that's not the end of the road at all. That's actually just like, now they really need to get some support around how to, all the social work stuff, all the psychotherapy stuff, that really needs to kind of come in more prominently. And that's kind of where I tend to do my work now, is working with people who are in a more stabilized state rather than people who are active, just because working by myself. and
Yeah.
and where my work is gone, particularly, is trauma work and developmental. So really supporting people and resolving unresolved trauma, which can act like real catalyst. So if someone's had significant developmental trauma, childhood trauma that they haven't resolved, that can get kind of pushed away or buried, and they kind of go through life and things seem okay, but then a sort of, a trigger happens, or they, significant stressors happen in their life, and all that stuff suddenly comes out, exactly like what happened to me, right, in my story. And then they get overwhelmed, and then they don't know what to do. And so what I've been trying to do is, like, I do lots of trainings, and I teach others how to work with trauma in different ways. And there's typically signs that that's starting to happen. Sometimes it can just be a sudden break, but oftentimes it's like the person's getting more and more stressed, and then, and then the break happens. And so if they can actually get help before they get to that, before they fall off the cliff, a good therapist, especially a trauma informed therapist, can make a huge difference for them. And I end up doing a lot of work with, like, social workers. I'll kind of work hand in hand with them to make sure that, I'll be doing more of the psychotherapy work, and then, have the social worker work on what's going on more in their environment and try to support them that way.
So you mentioned Soteria houses. So the Soteria project started by Dr. Lauren Mosher. Um,
Yes. Yeah.
could you talk about how those are structured? Because they do treat people in acute phases, right?
Yes.
So
So,
how?
yeah, well, there's first, I'll go to the history of kind of, there was would have been back in the 80s. There was quite a few, particularly in the San Francisco area in the US, but elsewhere. There was like Soteria, Diabasis, which had more of a Jungian kind of approach. There was I Ward, and others too that I'm kind of blanking on at the moment. And the idea there was and I'm not quite sure what the catalyst, why like they suddenly popped up at that particular time. I know the World Health Organization studies were already starting to come out, so that might have been a factor. But anyway, there was a recognition that the majority of people, if held right in first episode psychosis, can fully recover. So there was a real belief and even evidence for that. And so, and there's also evidence. So back then, there was actually a lot of research, and I have this in my book, doing long-term studies on people on and off antipsychotics. So someone has a first episode psychosis. There was actually trial, randomized controlled trials. Some people were put on the antipsychotics, other were put on anything. They're, given other psychosocial support, et cetera. And they found that in the short term, those on the antipsychotics did better, within a year. But after a year, those who didn't get put on the antipsychotics were actually doing better. And actually, and that happened again and again. And the psychiatric, or I should say the pharmaceutical industry, stopped doing those studies because it wasn't making the drugs look good. And so to this day, you will not find long-term studies like that anymore. Like I've looked and looked, and because it makes almost all drugs, antidepressants, anxiolytics, et cetera, stimulants, it's the same story: short-term harm, short-term benefit, long-term harm. So anyway, back to the 80s, they had this kind of information like, hey, the drugs seem to be hurting a lot of people in the long term. A lot of people recover spontaneously. Let's set up these residential kind of quote unquote blowout houses, they call them, and really hold them in a container that's really safe. So we're not going to let anyone hurt each other or themselves, but we're going to give them maximal freedom within that safety. And they didn't even hire like really highly specialized therapists. It was really just the criteria was, as far as the people holding the container, or that they were empathetic. So they had, strong skills in empathy. They were naturally compassionate and kind. And then they created opportunities for them to do things like expressive arts. They varied a little bit from each other, but generally the same. An opportunity to basically work with their experiences rather than trying to stop them. So someone's going into these extreme states and they might have extreme emotions. There'd be like a rage room where they could just go like beat on some pillows for a while. Or maybe they're feeling some real creativity coming up. They could go into an art room and they could really, or music, play with music or art to kind of let this creativity move through them and get integrated. And they had people who would listen to them and just empathize and really hear their story and help them to create a coherent narrative. And in general, they're having really great results. And this is all empirically, plenty of empirical data around this. And again, that magic 85% number was coming out again. About 85% of the people were fully recovering within like 6 to 8 weeks on average. And this became a huge threat for the status quo. And so the first Soteria House ended up, I guess there's a few, getting shut down without any clear reason by the state. They were having great results. And as far as I could tell, there was a lot of political lobbying against it, essentially, and to shut them down because it was really threatening the whole status quo. And then same with the other homes. They basically all got suppressed, shut down as well. And now they're starting to make a comeback, but it's hard because it's really hard to actually find people in first episode psychosis, because that's where they have the best rates of recovery if you can actually catch them right off the bat. Once they get institutionalized and they spend time in the psychiatric system and on drugs, it actually makes recovery a lot more complicated. So, like, let's say you have someone who's been institutionalized for a couple of years now. They've been on antipsychotics for a few years, and they've already been like inculcated in the belief that they have a broken brain and all of this. And then you send them to a Soteria House. It's actually going to be a lot harder for that house to be effective compared to if you can catch them like right off the bat. So that's kind of what those they're still they're still out there. There's a few out there and they're still working on it, but they're struggling with how do they get permission to bring people in right off the bat? And there's a lot of legal problems, with getting permission to do that kind of thing.
So at the Soteria homes, are they given the choice, like if they want to take meds or not? Are they ever forced upon them?
Well, again, it's changed a lot now, and I don't want to, and I know there's different opinions, but generally speaking, the philosophy has been, and I can't speak for any particular home now, philosophy has been to encourage the people to try no meds first. And I mean, typically, I mean, part of the philosophy is empowering people. Like if they're just like, oh, I just can't sleep, I really need some meds. And yeah, of course, help them. Oftentimes there'd be like a hierarchy, like start with lighter meds first, like give them some benzodiazepines first just to get them to sleep. And then, then pull those away. And then, okay, let's try antipsychotic. So there'd be a much more judicious use of meds. If so, starting with no meds at all, and then okay, benzos and maybe antipsychotics. So there'd be a kind of a much more judicious use of them, and then an attempt to try to get them back off the meds as soon as possible if things are stabilizing. So that the meds it was a totally different paradigm, or it is a totally different paradigm. It's not, oh, you've got this problem. It's not like insulin for diabetes at all. It's like, no, you actually need a little help just kind of settling down and getting some sleep. So then we can let your own psyche do what it needs to do with support to actually recover, to go through its own kind of breakdown process in the service of ultimately breaking through, to a healthy place on the other side. So that's the philosophy. Now, any particular home, I'm not sure exactly how they're going to hold that, but that's generally still with the philosophy they're working with.
Yeah. And as you point out, I think one of the biggest differences between that philosophy and, say, the institutional hospital route or paradigm of treating psychosis is the respect of autonomy and seeing the psychotic episode as a process the person is going through, not specifically an illness that needs um, medical intervention.
That's right, and that's a really big part of kind of my book. We hadn't really talked a whole lot about yet, but um, essentially, do you want me to say a little bit about that? Just kind of that paradigm about the
Yeah,
organic
I mean,
process.
yeah, I was actually wanting to transition into an alternative understanding of
Yeah.
what's happening in psychosis. So I think that'd be a good stepping
Okay.
stone or springboard into.
Yeah. And I'll try to put it into a nutshell. So if you consider, from infancy onwards, or you could even say really in utero onwards, we start developing a kind of worldview, right? This is the way beliefs about self, others, and world. We develop a kind of personal paradigm about the nature, et cetera, of the world. And if we're in a hostile or abusive or chaotic kind of environment, what we call developmental trauma, it's not always necessarily in the family. Maybe I'm in a war torn area, or maybe I'm experiencing a lot of discrimination, or, there could be lots of factors there. But anyway, if I'm essentially in a relatively hostile environment and I don't really get to experience much peace, and my beliefs about self, other, and world, reflect that, and actually become really problematic in many ways. There's a good chance as I kind of move and I get more and more developed, that my whole experience of self and world will reach a point where it's just no longer tenable, it's no longer sustainable. Like it's just, there's so much distress and suffering and kind of chaos and pain and confusion in my whole worldview. um it's this is theory, so take it what you want, but it seems to fit really well what I and a lot of other people have seen. There's a kind of spontaneous process seems to be directly initiated by our own psyche. Like this is no longer working, right? We need to break this down at kind of the fundamental layers of our whole cognition and cognitive constructs, and in the attempt to come up with something more wholesome, more adaptive, more present centered, right? And so rather than just, oh, we're just going to kind of edit these beliefs, it's like, because the kind of most limiting beliefs are right at the very sort of bottom. You might think of a skyscraper with a rotten couple first floors are really rotten, right? Like, what do you do? Like, how do you replace those? And so in many ways, the skyscraper kind of comes crumbling down, in service of a new building kind of getting erected. But that process of that crumbling down is the psychotic break, right? Like our whole constructs of self, other, and world end up becoming very flexible, they often can be very chaotic. But ultimately, it's in service of being able to build something more robust, more present centered, more adaptive. And if all goes well, that's what we see. And my own research kind of panned this out, that people who actually are allowed and supported, and whatever the factors that supported them to get through to the other side, end up coming out in a much healthier place than what they went in. So if you measure their state of kind of mind prior to the psychosis and then after the recovery, they're often better on almost every metric. Their sense of joy and peace and love and just general functioning. It's generally better. So it's not that they just recovered; they actually like went through a kind of profound healing process. And I found that again and again, in my own research, and I told you my own story, and I know so many other people with very similar stories. So it's not about romanticizing psychosis at all, because people they can end up stuck in a really terrible kind of nightmare indefinitely, right? I mean, it's a real risk. It's not something you would want to like wish on somebody. But ultimately, when it does move through, that's what you often see. And you can see that. So with psychedelic assisted therapies now that are kind of coming more and more prominent, I see that as basically the same thing, right? So when you take a psychedelic, what's happening in a way, you're kind of like loosening all the constructs of self, other, and world, at least for those few hours that the drug is taking effect, and it creates an opportunity for maybe something more wholesome to emerge or not. I mean, it depends on how that psychedelic trip is held, because it could make things worse for the person, right? But just like with psychosis, except it's you don't need the drug, you don't need the psychedelic. It happens spontaneously, and it tends to take a lot longer, and it tends to be a lot deeper. So that's kind of in a nutshell of how an alternative way of seeing this, a desperate attempt of a suffering psyche to try to move into a more wholesome place.
And like you said, it's not something you would wish upon anyone or romanticize, but it does seem to be initiated by the psyche for a reason. And once that has started, um, the best approach from what you're saying is to support the person through that process, which is what someone like, we haven't talked about them yet, but you did mention diabasis,
Yeah,
which John Ware Perry started, who was a student of Jung's. And he saw psychosis, similar as to what you are saying, as a renewal process where
that's right.
there there is a self-image or world image that is no longer tenable. Um, the person can't tolerate anymore, and so the psyche initiates psychosis to try to bring about a renewal of the personality. Um, so we haven't got to talk much about um, your specific paradigm, which I know you have your own model in your book. You talk about the DUI model, the Duality, Unity, Integrative model. Um, could you talk a little bit about that? I know you've already
Yeah,
mentioned some things that feed into that with your explanation of psychosis. But
yeah. First of all, very compatible with John Ware Perry's work. There's a great book called Trials of the Visionary Mind by John Ware Perry, which I highly recommend. A short read, but really, really deep, and really drawing from the indigenous, not only Jungian, but also indigenous perspectives, which, most of us are aware of the term kind of shaman or shamanic crisis or shamanic illness, which is basically the same thing we're talking about. So what this whole process we're talking about, as far as we can tell, like it seems to have existed and still exists within all human communities, going right back to hunter and gatherer times and this kind of thing. The difference is that indigenous societies treat it as this is actually a spiritual crisis. If the person is supported, they can go on to become a great medicine person, right? They can actually help heal other people. And the evidence is actually, that's what the World Health Organization kind of revealed, is actually those kinds of more collectivistic societies, actually that kind of was true. They held it in a more spiritual, hopeful light, and most people were fully recovered and actually became really, really beneficial to their community. So yeah, I just want to put in a plug for John Ware Perry's work there. Mine is very closely connected to that, and I definitely was inspired by his work. So the duality, unity, integrative model I talk about essentially weaves together a Western and an Eastern perspective, or I wouldn't even say Eastern because indigenous is included as well, but the unity kind of aspect of it is the fact that all life, the entire world, the universe, if you will, is profoundly interconnected, interdependent. And the experience of self, while here's me separate from you, it seems that's actually an illusion. Ultimately, we're all just different waves on the same sea of the cosmos, basically, right? So, and even quantum physics talks about that. And at the very deepest level of our experience, we kind of sense that we sense this really fundamental groundlessness, and the sense of like, and our own ego can experience that as a real threat. Like, hey, the sense of a solid self and a solid, secure world is actually not true. And that's actually, it could be either deeply liberating, like really, it could lead to euphoria, like, oh, wow, I'm that sense of oneness with the world can feel very euphoric on one hand, and or extremely terrifying, right? Like this existential annihilation, self-annihilation. And that's the domain that people often fall into when they go into a kind of psychosis. They often will tap into that real deep existential layer, and they often swing between euphoria and terror, or can go both ways for sure. Um, and so in a way, it's actually a fundamental truth. Like they're actually tapping into something that's really true that most of us don't really experience unless we have some really unusual extreme state, facilitated by maybe a psychedelic or something else. So that's the unity piece of the model. So that we could call that an existential dilemma that we all have to struggle with to some degree, even though most of us don't consciously struggle with it, but it's sort of there,
Mm-hmm.
that in our consciousness somewhere.
Could I intervene for a second, just ask a
Yeah,
question? So,
sure.
would you say that sort of the role of the psyche is to bring about an experience of the self to keep us from being overwhelmed by that unity?
Yeah, I wouldn't argue with that framing. No, I think I just had to think about that for a minute. I would almost kind of say that it's the role of the ego in a way. I mean,
Yeah.
which is kind of a part of the psyche. The ego is self, the I, and in order to function, here's the duality piece, right? So on one hand, you could say, yes, it's true. We're all just different waves on the cosmic sea, right? Like that is a fundamental truth. And when you really tap into it, it's freaking intense. Um, and it's also a truth, even though it's not a fundamental, it's more like an illusion, you might say, but it's a really important illusion that in order for this organism here, myself, Paris, right, in order for me to function and meet my needs as a living organism in this world, I have to have a kind of boundary between self and other. I have to have the experience of a boundary between self and other, even if it's partly illusory. And so we often call that the ego, or whatever. And that's kind of the dualistic aspect. And so there's a dilemma there in the sense that on one hand, yes, I have to have an experience of me with my needs, and I have to like function in this world and try to meet my needs and all of that. And also I have, as a social being, I have needs for relationship. I need relationship with other people and other beings and things like that. So we kind of have this dialectic. On one hand, we have this need for autonomy, for a sense of secure self and empowerment, et cetera. And on the other hand, I have a need for connection with others. So this kind of like, I call that the dualistic or duality sort of dialectic, because dialectic meaning it's both and, like it's not one or the other, like both sets of needs are really important. And so this is the other, you might say, if the basement level of my paradigm is the existential dialectic, this sort of dilemma of like, wow, how do I find security in a world that's fundamentally so insecure? There fundamentally is no self. You could say that's the basement level of my paradigm. The first floor is going to be the dilemma of this kind of relational dialectic. Like, how do I, on one hand, feel empowered and have a sense of autonomy, and on the other hand, feel connected, a sense of belonging and acceptance by others. And so that's when we get into things like attachment theory, we're in that level. And so these are like the two base levels of my whole paradigm. And typically everything else gets built on top of that. And so that's why developmental trauma is so important, because if those two foundations don't get built well, I don't get the sense of a relatively secure self in a relatively secure world. I don't feel like my autonomy and my authenticity is actually loved and accepted by important people in my life. If I don't get those needs met in my early years, that creates a real vulnerability. My skyscraper that gets built on top of that is built on two rotten floors, you might say. And it makes it very likely or possible that my whole skyscraper, my whole paradigm could collapse. And so that's where you might say the predisposition or the vulnerability to psychosis, why it's so correlated with early developmental trauma,
Mhm.
because of those two floor layers. And when it collapses, then a person kind of falls right into those two base layers. Like they're like drowning in those, that whole sense of, oh my God, myself is dissolving. My whole experience of the world feels so insecure. And I end up often grasping to try to find some sense of security in the world. I grasp for some kind of belief system that feels like I can hang on to. And so that's why when people fall into these states, there's often this grasping from one intense belief structure to another belief structure, right? That can just seem so crazy to the rest of us. but they're like drowning, trying to hang on to something that feels secure. Right.
Mm.
And there's also often that flip flop between extreme, kind of between these extremes of an extreme reified sense of self, which often a person can experience as very depressing and isolating, and an extreme, the other extreme, which is like extreme unitive type experiences, which often will show up as more like manic, like where the sense of self feels either very grandiose or even just kind of dissipated altogether. So this is where, like terms like bipolar disorder and schizoaffective disorder and schizophrenia are really all just pointing to the same process. But they're pointing to like, how is it actually manifesting for this person? If there's a lot of swings between those experiences, and we often give them a bipolar label. If it's more cognitive and they're having a lot of kind of real kind of wild belief systems, and perceptions, hearing, auditory perceptions and this kind of thing, then we tend to call more schizophrenia, or schizoaffective would be kind of somewhere in the middle.
Mm.
So that's kind of my best crack at putting that into a nutshell, into my, the duality unity kind of
Yeah,
integrative
you,
model.
you, you tied that together very nicely.
Thank
Um,
you.
so what you're saying is there's this sort of dialectic that's the foundation of a stable sense of self in the world. And on one hand, and you talk about this in your book, and you point to earlier psychologists like Otto Rank and Rollo May, who also kind of had similar dialectics between our need to be an empowered individual, individuate, have autonomy, and then on that side of the spectrum, if you go too far outside your window of tolerance, there's a lot of existential anxiety around, being alone, isolated, feeling disempowered, maybe. And then on the other side of the spectrum, there's the desire, the need to belong, to merge, to connect with a group or others or the world. And on that side of the spectrum, there's the existential anxiety of losing your identity, of engulfment, and that
Yeah.
a lot of what we call psychopathology can be reframed and looked at through this lens of um, which side of the spectrum are they having trouble with, or not being able to reconcile both of those needs. Is that right?
Yeah, that's right. Like, and we can frame that in attachment theory as well. So in attachment theory, the idea is, how do we relate to other people? Where's our comfort zones? So someone might be considered in a more avoidant, insecure place if they're more comfortable with the autonomy end of that spectrum, and less comfortable with connection. Too much intimacy will quickly feel overwhelming, like I'm losing myself. So that person is more, we often call them avoidant, insecure attachment. Or the other extreme, where they're not very comfortable alone, they're much more comfortable in relationship, and they can get kind of clingy and terrified of they're particularly terrified of getting isolated, right, of getting abandoned in isolation. So we often call that anxious or ambivalent insecure attachment. And then there's disorganized, which is where they kind of flip flop between the two, which is typically indicative of more severe trauma. So yeah, that's just kind of using contemporary language for all that really wonderful work that people like Otto Rank and Rollo May and these others have done. Attachment theory provides a really nice framework for exactly that continuum between autonomy and connection, and how we can kind of get fixated on one side or the other, or more terrified of one side or the other. And then the people who are more likely to end up in going into a more psychotic process place, or where both sides are actually really scary for that person. Like, they feel like they're damned if they do, damned if they don't. It's like, too much autonomy, and then I get overwhelmed with isolation anxiety. Too much intimacy, I'm overwhelmed with engulfment anxiety, I'm losing myself. And they kind of get squeezed in this impossible pickle where they can no longer find security anywhere. And so that goes with the kind of disorganized attachment style, if you want to use that particular lens. But it's also, there's a real correlation between that particular presentation and psychosis. And it makes sense because it's such an unsustainable way to live, right? Just terrified all the time, basically, right? There's no security anywhere.
So would you say that what we'd call symptoms of either, say, psychosis or even like mania are attempts by the psyche to try to compensate for um, instability on some level within that dialectic?
Yeah, that's right. So we're trying to, so if you want to say the psyche as a whole, the psyche as a whole, like again, we have different aspects. So ego is particularly focused on like maintaining a secure sense of self, for example. But the psyche as a whole is actually trying to maintain a balance. Because if there's too strong of a sense of self, right, then we fall into usually like deep depression and just isolation, and right, it's not really a good way to live. Um, and then on the other extreme, if we have too little sense of self, right, then we're vulnerable to, well, following into that kind of existential terror or maybe mania if it has a kind of more euphoric or enthusiastic flavor to it. So our psyche as a whole is trying to maintain a balance. It's where all of our needs can be met: needs for relationship, needs for autonomy, needs for empowerment of self, but also needs of ease. Being able, and that's kind of when we talk about the spiritual needs. You don't have to have a particular religion or anything like that you follow, but the definition of spirituality I like is connecting to something larger than the limited self. For a lot of people, might just simply experience that as connecting to nature or whatever, but that's a really important need for us to not be totally suffocating in a too strong of a sense of self, right? We need to have some sense of feeling connected to the broader world. So that balance, in a way, you've kind of got these two continuums, if you will, that are very closely linked, but of balance between too strong or too weak of a sense of self. And then when we're kind of in the self territory, we're thinking more, okay, here I'm in my sense of self, between autonomy and connection with others. So that's a healthy psyche does that automatically. We don't really think about that. And what'll happen is if we start getting imbalanced on one side or the other, we'll feel a natural pull to the other side to balance. So if I start feeling too much alone time, I'm going to start feeling a strong impulse to connect to others, right? And so then I'll pull. But once I get too much time with others, I'm like, okay, I need some me time now, right? And you could use that on the other continuum as well. I start feeling like this real stifled sense of self. I just need to get some fresh air. I need to maybe just go for a walk and connect with nature, or maybe if you have a more religious tendency, maybe pray or meditate or something like that. And then, but if you go too far in that direction, right, then we need ground. We need to like feel my body, feel the sense of connection to ground and solidity. So it's kind of, in a way, that's a big part of what I do when I help people is, okay, they're kind of imbalanced here. How do I help them get balanced? Like I really like the Icarus. Are you familiar with the myth of Icarus? Who it was a Greek myth of I won't spend much time. I'll say a snapshot of it, but him and his father had to escape this island, and they built these wings made of feathers and wax. And the father told the boy, because he knew the boy was going to love flying. He's like, be careful. If you fly too close to the sun, your wings will melt, right? You fall in. If you fly too close to the water, you'll get wet and you'll drown that way. But the boy couldn't help himself, and he got higher, and it was so fun. He got higher and higher and closer to the sun, and his wings melted, and he drowned. So it was kind of a tragic ending. And so when I'm working with people who are in extreme places and stuff, that myth is sometimes helpful. Like we need a kind of balance here. You're getting a bit high. You're getting too close to the sun. We need to actually connect to earth. We need to connect to ground, body, nature, feel the wind on feel your senses, right? And then in the other extreme, like you're getting into this really dark, depressed, stagnant place. What would it be like to go ahead and do something that was a little bit, that loosened your sense of self a little bit? Maybe do some meditation, go on a retreat, etc. So yeah, so that balancing act is hopefully automatic for most people, but for many people it's not. And then supporting them in that really helps.
So I want to be mindful of your time. I know we got to wrap up here pretty quickly.
Yeah.
I just want to mention real quick the other two myths in your book was one that schizophrenia is a valid construct or concept, which we don't have time to get into. But I think if people go back and listen to your explanation on how the sort of underlying dialectic or needs between the self, the individual, and then belonging to a whole, how that sort of meshes together different presentations of what we would call psychopathology. And the other one is that modern treatment, the other myth that is that modern treatment has increased results for people diagnosed with schizophrenia. So my one question with that is, from what you know with your research over the past, let's say four or five decades, has anything gotten better for people diagnosed with schizophrenia?
Well, yeah, I mean, there has generally, again, it's very stuck still, but there's generally been a recognition that the brain disease model is flawed, So that's become more mainstream now, recognizing, the whole biochemical imbalance theory and all of that. That's become much more mainstream. In fact, even like, leaders in the psychiatric field are acknowledging that as well. That has never panned out. That hypothesis that there's some neurotransmission imbalance, at least for the most part. I mean, I'm not going to deny there's certain cases where, yeah, there may be some physiological issues for sure for some people, but in general,
Mm.
we're talking about here, that's more the minority, at least initially. Um, so that and a general movement towards more holistic approaches to supporting people, kind of recognizing. I don't think anyone would argue, no matter what belief you come from, that distress is a factor in at least worsening your condition. I think like kind of hardened reductionistic psychiatrists would sort of acknowledge that. So there has been more movement in like, how do we help people kind of meet their basic needs for nutrition and social connection, and trying to not be stuck in traumatic environments. And so that seems to have gotten better, but that's after coming from a huge dip in the 70s, 60s, and 70s. There was actually this really optimistic movement towards family therapy and this kind of thing, which was
Mm.
actually having really great results. And then that got completely like swept, almost completely swept away, and by the bioreactive model. But that's starting to make a comeback. Like the open dialogue approach in Finland, I told you, like has really helped, and other sort of systems theory methods have definitely been making a comeback. But unfortunately, they're still on the fringes. So yeah.
Well, Paris, I really appreciate your time and talking to me and sharing your wisdom and knowledge on the subject. And there's a lot we didn't get into, and hopefully you'll come back again and we can talk about more. Um,
Yeah.
could could you plug your websites for people who want to learn more about your work or who need some sort of support or help or resources?
Yeah. So Rethinking Madness, all one word, rethinkingmadness.com is a website for my book. You can actually download a free PDF of the entire book right there if you'd like.
You
Or
should
you
buy
can,
it. Though.
yeah, yeah. You could definitely, yeah, buy it from Amazon and all the kind of major booksellers. And then there's also a resource directory that's really good, and lots of my other articles and some webinars there. And then my private practice is just my name, Paris Williams, PhD.com. So those are probably my two most relevant sites.
Perfect. And I'll plug both of those in the description whenever I
Okay.
post this. But I know you got to go, so I'm going to let you get out of here. And thank you again for being my first official guest. I really appreciate it. And I hope
Yeah,
you
it's a real honor.
have, and have a good day with whatever you're doing.
Yeah, you too, Zach. Thanks for having me.
All right. Bye, Dr. Williams.
Okay, take care.